Hi, my name is Desiree Morgan, and I'm from the University of Alabama at Birmingham. And today I'm going to talk to you about dual energy CT of the pancreas. And specifically, we're going to talk about GSI, or gemstone spectral imaging. So let's get started. These are my disclosures. And the objectives of the next 15 minutes or so are for us to briefly review the physical principles of dual energy CT, to discuss state-of-the-art DECT for pancreatic ductal adenocarcinoma patient evaluation, to apply those principles to other diseases of the pancreas, and finally at the end I'm going to show you some cases and actually go through them using both the GSI server and PACS so you can see how this will work in your practice. So before we get started in earnest looking at images, a little bit of physics review is necessary. You all are familiar with the term kVp, and basically kVp denotes the highest energy X-ray in a polychromatic beam, and when we do regular single energy CT, we're generally sending a 120 kVp beam through a patient. KeV, on the other hand, talks about an individual X-ray photon energy in a spectrum. So a 120 or 140 kVp polychromatic beam contains energies throughout the spectrum, as you see in this graph here. Now with dual energy CT, one of the basic principles you need to remember is, unlike single energy CT, where the degree of density or the brightness on the image is due to physical density alone, with dual energy CT, because we're sending the two beams through the patient, we're looking at the attenuation of various materials at high and low energies. And it's actually the difference in attenuation between high and low energy that determines what the material is. So if you look at these curves from the National Institutes of Standards and Technology, you can see that for iodine at lower energies, there's a higher attenuation. And the difference between the low and high energy is very different for iodine compared to calcium. And if you think about it, on a regular CT, they're both bright. But with dual energy CT, we can tell the difference because of the difference in attenuation between the high and the low beams. And so when you're thinking about this for a patient, there have been phantom studies that have shown that basically 77 keV monoenergetic images are visually similar to 120 kVp CT, single energy CT image. Now in our clinical practice, we started looking at 77 keV images as our PACS equivalent, since most of our patients are studied with 120 kVp beams in a single energy mode. But in reality, 70 keV more closely approximates what we see when we're doing dual energy, monoenergetic imaging compared to single energy at 120 kVp. So our PACS equivalent at UAB is 70 keV, and you'll understand what that means in just a few moments. So when we look at where images come from with this particular rapid kV switching dual energy CT machine, we are acquiring images from a single source, and that source rapidly switches between the two energies. The MA is fixed. And so basically a very rapid detector on the machine has data that's from the 80 kVp beam and from the 140 kVp beam. And that detector data does not go to generate images at 80 kVp and 140 kVp. Rather, they combine them in mathematical space or projection space to create images. So what are the kind of images that we'll see with dual energy CT compared to single energy CT? Well, you've probably heard simulated or virtual monoenergetic images. Those are biggies. Those are the PACS equivalents that we'll talk about. There are virtual non-contrast images, iodine material density images, and these are the three workhorse images that you'll use in your daily practice. Again, the 120 kVp beam is roughly equivalent to 70 keV monoenergetic images, and so you're definitely going to want to send those to your PACS. But at UAB we send not only 70, but 52 keV images, and by the end of this presentation you'll certainly understand why. Now, there are other images that are able to be generated from dual energy data. Those include material suppressed or material enhanced images, something called Z-effective images. People are using those, but mostly that's in the research space. And we generate those on our independent workstation, whereas these others, the simulated monoenergetic image, the virtual non-contrast image, and the iodine images, they're generated right at the CT console at the time the patient is scanned automatically, and they automatically go into our PACS. So there's nothing you as the radiologist needs to do to generate those images unless you want to using an independent workstation, if you set it up to have that done directly by your CT techs. Now, we at UAB have the client-server version of the GSI viewer, and that's really helpful if we want to delve deeper into the dual energy information. So what's it look like? In 2016, for our multiphasic pancreatic CTs, here's what we do. We do a conventional unenhanced single energy 120 kVp image that you see there on the left. We do a pancreatic parenchymal phase dual energy acquisition. There you see the 70 keV, looks like a regular arterial scan of the pancreas in this patient who's got a small tumor in the left aspect of the pancreatic head abutting the superior mesenteric artery. And then we also acquire portal venous phase images with single energy CT. Now we don't just look at the 170 keV image, we're actually looking at the 52 keV that you see there on the bottom and the iodine and water basis pair that you see up at the top. In other words, when I look at my image rack for a pancreatic CT, I don't get 3 images, I get 3 images plus the 4 versions of the dual energy CT information. And some practices, I realize, don't use conventional unenhanced imaging. You can actually use dual energy to generate that image with virtual unenhanced imaging. And here I will show you some patients where we are going to be using color to bring out pathology, and we tend to do that on the server. We don't send color images into our PACS. So if we take a look at this patient who has a pancreatic ductal adenocarcinoma in the tail region, you can see in the image on your left, the portal venous phase CT, it's barely perceptible there. Simply by doing the arterial phase acquisition or the pancreatic parenchymal phase acquisition in the middle on the 70 keV, you definitely can see that tumor, the margins of the tumor, much better than on the portal venous phase. Now if you look at the iodine image on the right, I would argue that the sharpest margins, the best depiction of where that tumor is in this patient's pancreas occurs on the iodine images. So now if we look at that same case but on the GSI workstation or server, here's what you get. And this is the typical representation if you select a post-processing software version called MonoMD Compare. And what you see, just disregard the graphs on the left for a moment. What you're looking at in the top center is the image you just saw from PACS, and that is the 70 keV simulated monoenergetic image. I've placed an arrow pointing to a small region of interest outlined in red in non-tumoral pancreas, and a yellow arrow pointing to a region of interest in the tumoral pancreas. And with one click over in the graph section on the left, on the upper, I can turn this into a spectral Hounsfield unit curve. And what that does is it shows the attenuation with within the pixels of that region of interest across all the available energies available to us using dual energy CT. And so you see from 40 keV on the left side of the graft up to 140 keV on the right side of the graft, there is a divergence in the contrast between tumor and non-tumoral tissue, and the difference is greatest at the low energies. So if we look at 70 keV, which is the shorter blue bar in the middle part of the graft, that's the degree of contrast difference between tumor and non-tumoral tissue at the PACS equivalent energy level, if you will. But if you look at the 50 keV image and then look at the degree of separation of tumor and non-tumoral tissue in the larger blue bar on the spectral curve, you can see that there's almost double the amount of contrast difference. Now when you look at the 50 keV image in the upper right, that's not an image that you would want to use for routine diagnostic purposes. It's too contrasting. That's because it's windowed and leveled at 440, just like standard abdominal CT. We'll talk about that in just a minute, but I also want to point out on the bottom row, you see the water and iodine basis pair. And these are post-contrast images. The water does have contrast there, but the iodine basically has been electronically subtracted through calculations. And then the iodine image has removal of water. So this represents what people tend to call an iodine map or iodine material density image. So if we look at how we determined that we should be looking at 50 keV images, back in 2009 when we got our first scanner, we didn't know how to use it. We knew that we wanted to use a PACS equivalent image to do our routine diagnostic viewing, and that, after a little bit of trial and error, became 70 keV. But if you look, the machine can also calculate for us the ideal energy level that's optimized based on a contrast to noise ratio. So in this patient who has a larger pancreatic ductal adenocarcinoma in the body region, you can see that I've placed regions of interest in the tumor and non-tumoral tissue. Again, just on the graph with one click, I can generate this CNR optimized curve in the upper left. And in this particular patient's tumor, their individual tumor features suggest that the best energy level to see the difference between tumor and non-tumoral tissue is at 49 keV. and that's the image that you see in the lower right. So I've kept the level on purpose at 40 and the window at 400, so you can see the difference in the image that's due solely to the difference in energy level. There's no window and leveling that made it look that bright. So that begs to ask then, what is the ideal window and level for a low energy image? And we're going to get to that in just a moment. So one of the first experiments we did, because we didn't really know how to look at patients with pancreatic ductal adenocarcinomas optimally with dual energy CT, is that we took 64 subjects who had the tumors path proven. We did our dual energy CT acquisition in the pancreatic parenchymal phase, and we looked at these tumors three ways. We looked at the 70 keV image, our PACS equivalent image. We looked at the CNR optimized keV, which we calculated for each individual patient. And then we looked at a really low image, knowing that the K-edge of iodine approaches the 40 keV end of the spectral curve. And here's what we found. We basically had a doubling of the contrast difference between tumor and non-tumoral tissue at the CNR optimized level. We also gained some contrast at 45 keV, but because of noise, those images were not very favorable. And you can see from the tumor length measurements that the margins look different at the different energies. So basically what this meant was, for an individual patient, when we went from the 70 keV to the CNR optimized keV, we gained 57 Hounsfield units. We found that the median value was 50 keV, the mean was 52, and that's why we now use 52 keV images for our routine clinical viewing. And here's what we surmised, that viewing at lower energies, but perhaps not the lowest, using GSI may help us to identify what regular state-of-the-art single energy CT cannot help us identify, and those are non-contour-altering isoattenuating masses, small tumors that we're trying to find in this patient population to positively affect outcome. And we also thought it might help us to depict tumor borders for resectability predictions. So now if we step back to the images I was showing you from the later case, not the 2009, but the 2014 case, we're going to show you the effect of appropriate window and leveling of that 52 keV image. As it turns out, that's about 720 and 105, and we have that programmed into our GSI viewer so that with one button, I can get that to come up. Now, I also want to show you this set of images, and this is the same level of tumor, the same tumor that you've been looking at different energies. So you can see that as you go from the low energies where you have the maximal contrast difference to the higher energies at 140, you're actually getting rid of contrast as you go to the higher energies, and that makes sense when you look at the curves. So if we look at the numbers and apply the images to the spectral curve, you can see that all the attenuation, all the Hounsfield unit numbers go up at the low energies, but so does the delta between tumor and non-tumoral tissue. So you definitely want to be looking at the 50 or 52 keV images when you're trying to find a soft tissue lesion in the pancreas or even in the liver or other solid organs of the abdomen. So here's what it looks like in real practice. We're going to step down through this patient's pancreas. You can see from the initial image that the duct is dilated, and we're looking for the tumor that we know must be there causing that duct to be obstructed. We're looking at the duct through the neck region. All of a sudden, it goes away. But where's the tumor? Where are you going to measure that tumor? How big are you going to tell the surgeon that tumor is when you can't see the margins of it? Well, this is a very nice pancreatic parenchymal phase acquisition if you look at the contrast in the aorta, yet this tumor is isoattenuating to the remaining pancreas parenchyma. Well, now I'm showing you what it looks like when we put a patient that we suspect has a pancreatic cancer into our pancreas adenocarcinoma protocol on the GSI viewer. So we have side by side 70 keV on the left, 52 keV in the middle, and iodine material density images on the right. And you can see the windows and levels there. If I appropriately window and level the 52 keV image, look for where that bile duct is dilated in this patient, you can see that there's an oval mass depicted by the arrows there. And I think that looking at them side by side, the 52 keV image appropriately windowed and the iodine image really show the tumor better than the PACS equivalent 70 keV image. So while there are plenty of patients with pancreatic ductal adenocarcinoma that you can see actually on portal venous phase, many more that you can see with pancreatic parenchymal phase at 70 keV, there are some that you really can only see using the dual energy, lower energy and iodine images that I'm showing you here. So we did a second experiment because the first one involved patients with large tumors. We were able to see them and put the regions of interest in to calculate the CNR optimized energy levels that we should be used for viewing. And when we started placing our 52 keV images into PACS, we wanted to see how this helped us find the what we were seeking, basically the non-contour-altering isoattenuating tumors. And so here, if I just step you through this experiment, we had a smaller population, 50 patients that had pancreatic dual energy CTs, and this was a multi-reader study. And I basically used the feature of the GSI server where you put a single region of interest in and it populates across all the images in the exact same place, so I could measure the difference between tumor and non-tumoral tissue, and basically saw that, again, at the 52 keV level, we basically doubled the contrast difference between tumor and non-tumoral tissue, making them easier for you to see. Well, then I found 3 friends who were willing to go through 50 tough cases of small dual energy CT pancreatic cancer patients, and they read them separately. So in other words, they read the 70 keV images in random order. They had a period of weeks where they waited so they wouldn't remember. Then they looked at the 52 keV images, waited, then looked at the iodine images. And when I averaged out what their results were, the same thing was found. In other words, there was a doubling of the contrast difference at the low energies, and their values were very close to mine. So this is actually doable by everybody. You don't have to be an expert. You can do this too. The other thing was we finally started looking systematically at the iodine images, and because the contrast noise ratio is so good on those images, we found that we preferred them. I mean, just visually, they're very nice once you get used to looking at them. So here's what we found from our second study. Again, it was smaller tumors, less than an inch. We measured objective image analysis and found that the kappa values were highest for regions of interest measured by our readers on the 52 keV images. So they were good for objective analysis. But when we asked the readers what they liked best, we still found that they liked the 70 keV images just for looking at the abdomen. In other words, things that were familiar, the liver, the kidneys, other things outside the pancreas, they thought looked best at 70 keV, and that makes sense. But they also found that the iodine material density images gave them the highest confidence that a lesion was present, and it gave the highest conspicuity scores for the iodine images, again related to the great contrast noise ratios of that particular way to look at things. So what we decided at UAB was that material density and low energy keV images are complementary to the standard 70 keV images, and we look at all 3 in our routine viewing. Others have found the same thing, so I'm listing for you here different publications that talk about pancreas pathology. Some are pancreas adenocarcinoma, some are pancreatic endocrine neoplasms, and you can see that there's agreement early on with the rapid switching modalities, but even now, even the dual source, dual energy CT, folks are looking at monoenergetic images to look for pancreatic adenocarcinoma and other pathologies in the pancreas. So if we take a look at this case of a 67-year-old man who came into the emergency room with abdominal pain, he had a portal venous phase single energy CT, and again we can see the pancreatic duct as we're marching inferiorly through the head region, and he has a tumor there and we can't see it. Okay? If we just do a multiphasic exam, so here you see now the arterial or the pancreatic parenchymal phase of that same patient. If you look carefully, you can see that there's a small tumor in the anterior head region. If you look at the coronal images on the bottom row, you can see the demarcation very nicely. And if I show you the regions of interest, you can see why you see it better on the low energy and iodine images. Here's a different patient with a small pancreatic ductal adenocarcinoma. She's a 60-year-old woman who came in with abdominal pain and a first episode of pancreatitis. And you know that one of the reasons that someone may get pancreatitis later on is a tumor. So where in that pancreatitis do you see the tumor? Again, if you look at the 70 keV, the 52 keV, and the iodine images side by side and scroll, which I'll be able to show you live at the end of this presentation, there's a very small tumor there. And basically we have found that on the 52 keV images, we can definitely see things that are about 100 Hounsfield units difference. We definitely can see them at 50 or 60, and below that it starts to get tougher. Another reason that you may want to use dual energy CT is that we have gained some success in the neoadjuvant treatment of patients with pancreatic ductal adenocarcinoma in tumor shrinkage and enabling them to have attempted surgery. But things get a little messy. And if you look at, again, our first patient, if you look at the portal venous phase on the right and the 70 keV and iodine images on the pancreatic parenchymal phase on the left, after therapy, her tumor got tougher to see. It got smaller, yes, but when you're looking for the margins, I would argue that on the image on the lower right, you cannot see the margins of that tumor with the normal pancreas now. On the images on the left, the dual energy images, you at least have a chance of understanding where the tumor ends and where the normal pancreas begins. And this is important for not only resection, but also if you're going to do local therapy like irreversible electroporation, or IRE, which we're using at our institution. Now, I've been showing you hypovascular pancreatic ductal adenocarcinomas thus far, but the same principles in gaining the difference in contrast between tumor and non-tumoral tissue exist for hyper-enhancing lesions like pancreatic endocrine neoplasms. So in this tiny little 6mm image in the pancreatic tail, you can see it on all three images, 70 keV, 52 keV, and iodine images. And others have found that you can increase sensitivity for detection by looking at monochromatic and iodine images. You may want to use an iodine overlay, and so this is the same patient. I've just clicked a button on the GSI server and brought this into a different way to look, and I want you to concentrate on the image on the middle right. That is an iodine colorized overlay on a 52 keV image, and this makes hyper-enhancing lesions stand out. So some argue if you add color, you make your job easier by seeing things faster, and you may want to incorporate that into your practice. These are already available as presets on the GSI server, and people refer to this as the iodine map. Here's another patient with a tiny little tumor. This one is a cystic degenerated pancreatic endocrine neoplasm, again less than 1 centimeter, and we can tell it's different than other potential cystic lesions because of that hyper-enhancing rim, and that hyper-enhancing rim is better seen at low energy and on the iodine images. Now, you do not need dual energy to see this patient's tumor. This is an 18 centimeter pancreatic endocrine neoplasm that basically fills the whole gland. But what's important in this particular disease is to not only find the tumor, but to find the metastases, because nowadays surgeons will debulk these patients by taking out the primary neoplasm, lymph nodes, and up to 5 metastases, which was the case for this patient who had successful resection. There are other kinds of lesions besides solid lesions in the pancreas, and we're going to take a look and just consider cystic lesions for a moment. This is a patient who has a side branch intraductal pancreatic mucinous neoplasm, or IPMN. And if you look at the image on the left, you can see the solid nodules and septations in that lesion. And we know that those are findings that are worrisome features. So when patients are considering surgery, if we identify those, they should be more likely to have resection because they may be more likely to be malignant. And if I show you this movie now, we are going to keep at the same level of that tumor, but we're just simply dropping the energy. And so you're going to see that happen now. The effect of decreasing KEV on those nodules and septations kind of popping out at you. Again, the image does get noisier, but we're going to use the calculations in dual energy CT to help us visualize that better. One way to do that is to add color. And so one of our ways that we like to look at cystic lesions of the pancreas is to look at low energy and add a color filter. This is just a simple grayscale color filter called the French filter. And if we look at this patient who has a different side branch IPMN, this one with less nodularity, if you look at the grayscale image on the left, you can see it's 70 keV with the colorized filter on. The green in the lesion looks similar to the water in the stomach. We don't give oral contrast for our patients with pancreatic adenocarcinomas or pancreatic masses before their CT. We use water for a dark contrast agent. Now, it's interesting when you look at the 52 keV images with the filter, something is different about the liquid in that cyst compared to the water. We know it's water in the stomach. And if you look at the numbers, the Hounsfield units go up and they change to a different degree in the mucin that's in that tumor compared to the water in the stomach. And we might be able to use this to help identify lesions that contain mucin, such as an IPMN. Okay, others are looking into the same thing. So here's a patient looking at the images on PACS with unenhanced, a 70 keV dual energy image and a 120 kVp single energy portal venous phase. Here's a cyst in the mid-body region of the pancreas. What is it? If we pop it into our typical GSI protocol for pancreatic ductal adenocarcinoma, you know it's high contrast because it's cyst compared to the normal enhancing pancreas anyway. So that doesn't really help us. If we put it into our pancreatic cystic protocol, again, this is just a push button feature that you'll see me use at the end of the presentation. Click of a button, we're looking now at a mucin image on the lower left, the 52 keV image with the color filter on the right, and we're looking at the content of that lesion, which is clearly different than water. But is it mucin? One hint as to what this is doesn't really come from the attenuation, but it comes from looking at the margin, and that is a hyperenhancing margin, and this is a cystic degenerated pancreatic endocrine neoplasm. So there are other reasons that there may be fluid around the pancreas. Pancreatitis is one of them. And this is a different patient now who at presentation looked like he had interstitial edematous pancreatitis. But 25 days later, you can see that there's focal glandular necrosis in the head and neck region with some extrapancreatic fat necrosis in the acute necrotic collection. Can dual energy CT help us identify when there's residual pancreas in those collections, which tend to look uniformly low in attenuation nearly right away? So here, I've just popped it into the GSI server in our standard pancreas adenocarcinoma mode. You can look at this to look for iodine to see if there's residual iodine in that area that looks dark on the CT. Or you can try the cystic mode here to look for whether or not it's just purely fluid, which it's clearly not in this case in the lower right. And you may not want to look at mucin. We don't think that there's mucin in here. We think that we're looking for enhancement. So you can change what's in these boxes. You have your presets, but you can change. Anything that's red can be changed. And here we're changing from a mucin image to an iodine image and looking at the enhancement that way. So these are just different things that you can do in your practice when you set up push button, one click, pancreatic adenocarcinoma protocols for post-processing versus a cystic lesion post-processing. None of it is stagnant. You can change these things on the fly. And that's what I hope to demonstrate soon. This is a volume viewer. So all the capabilities of an AW workstation are here in these windows that we're using to look at the dual energy information. So if you wanted to evaluate in a 3D way the relationship of vessels to a patient with tumor, or in this case the patient with pancreatitis, you can just pop the 3D volume in and rotate around like you would with the AW workstation without the GSI. And so with that, I'd like to show you some cases in real time using the GSI server. So now at the end of our image rack in PACS, we see the special dual energy images. And if you want to look at those just like you would a portal venous phase, so you guys look at these every day, paging through on PACS, the same thing happens for the dual energy images. So I'll move over here. We have the 52 keV image, the water image, and the iodine image, and these are called basis pairs. So we can just open up the 52 keV and the iodine image, and you can do this together side by side on your PACS or one at a time. And I can try to link them. I will change the window and level here because it's too contrasty. And then as we scroll, you can see the tumor that I've been showing you in the presentation in the tail of pancreas here on the pancreatic parenchymal phase, iodine, and 52 keV images. And I've got to unlink them to get to the same level on portal venous phase. Here's what it looks like there. So you can definitely detect the tumor and the margins better. And that's what it looks like on PACS. So now I'm going to share with you what it looks like in the special post-processing world of the GSI viewer. So the same patient will be loaded, and again there are a myriad of potential protocols. We have created one called the pancreatic adenocarcinoma protocol, which has side-by-side 70 keV, 52 keV, and iodine images. So you can see as the images are loading in, there's a whole lot of data on dual energy images. Now we have 70 keV images, axial on top, coronal on the bottom, 52 keV images in the middle, and iodine images. And everything that's red can be changed with this AW workstation. So to increase the field of view, you can either right-click or you can adjust it by putting in a number. So I'll do that so we can take a look at the tumor a bit more closely. And as we page up and down, you can see that my 52 keV images in the center are already windowed and leveled. This is a preset that we programmed in and saved as a post-processing step. Okay, so if we look at this patient's tumor, and I can drop some regions of interest into the tumor and non-tumoral tissue. Here the tumor, here the non-tumoral tissue. And if we look closely at the numbers, you can see that the tumoral tissue on the 52 keV is 100 Hounsfield units. It's 64 on the 70 keV set, and the non-tumoral tissue is 257. So the difference is 157 here at 52 keV, and the difference here at 70 keV is closer to 80. Okay, so just like what I showed you, you can do this in real time by dropping cursors, okay, and scrolling. And then it's easy enough to delete or just go to another level. If we look at the coronal images, you might want to look at the functionality of extrapancreatic extension. Here's the tumor. There is the non-tumoral pancreas around the splenic artery in this case. It's just a very easy post-processing world to participate in. So if we close this case out and look at a different patient with pancreatic adenocarcinoma, again, I'm going to select that particular software that's going to display the 70, 52, and the iodine images side by side. Okay, now we've loaded the patient successfully into the server. I'm going to make the images bigger, maybe not that large. To show you, we'll take off the marker that keeps us oriented in the volume viewer. And here in this patient, whether it's coronal or the axial images, you can see that the main pancreatic duct is markedly dilated in the tail. There's peripancreatic inflammatory change surrounding the tail of pancreas. And as we come on down and follow that dilated duct towards the head region, you can see that it ends in this fairly large mass that's in the anterior aspect of the head of the pancreas. And you can see what the mass looks like on the 70 keV image, on the 52 keV image, and here very clearly demarcated on the iodine image. An easy way to look at this particular patient's tumor is coronally, and if we get to the right image level, we can see the duct, the tumor, and the normal pancreas. I'm going to make it just a little bit bigger to drop some regions of interest in. Again, it's one click. We can come across. Here's the tumoral Hounsfield units. This is non-tumoral. We can move it very easily. And you can see the difference in those measures. If I click, the tumor itself measures 128 Hounsfield units compared to non-tumoral tissue of 279. And when we look at the 70 keV PACS equivalent, that difference is not as great. Okay, so just one way to look at it. You can also drop cursors in things you know. Substance here is the water. You can see that the Hounsfield units are 5, which you would expect to see. 13.5, that's Hounsfield units. It's really important to understand that the units of measure with numbers in these regions of interest are different based on the type of image it is. So for example, the virtual or simulated monoenergetic images, these are Hounsfield units. They are different than Hounsfield units at 120 kVp, but they are similar enough that they should be familiar to you. However, on the iodine images, these are not Hounsfield units. These are in terms of milligrams per cc of the material being studied. So here you can see the actual unit is times 100 micrograms. So if we have a value of 5.29, this is a value of 0.53 milligrams per cc iodine. And you can use that quantitatively, and some folks have done that looking at actually response to therapy. So now we'll move on to a patient with a different tumor. And again, this patient has an adenocarcinoma, a very small one, so I'm going to use the same preset software that I've been using. Now that this patient is loaded into the viewer, we're going to start by magging up, and I will tell you that some of our post-processing presets involve shrinking the region of interest down. So for our adrenal protocol, for example, you already get the images magnified and you don't have to change the field of view as I'm doing for these images in this presentation. But let's take a look now very carefully, because this patient has an extremely small tumor. If we look, and again, I like to look at the iodine images, so I'm going to scroll over here, but it'll move all of them. This patient's tail of pancreas is atrophied, their duct is dilated, and the action is always where the duct goes away, and in this case, there is a tiny little tumor measuring 1.3 centimeters in the neck of the pancreas. Now, if I mag up even further, and remember, these are source images, so you're looking at noise. This is the worst this image is ever going to look, and it actually looks pretty nice. So what we want to do is look at the anterior margin of that tumor to see if it's spread beyond the pancreas. And I think the iodine images show it best. This actually was a 1.3 centimeter, but T3 lesion, meaning that it had entered the extrapancreatic fat. Finding that on the coronal image is a little bit of a challenge, but what we can do is place our cursor in, because remember this is a volume viewer, and we go straight to the level of the tumor where it's obstructing the duct. Again, dual energy CT can show us things we've never been able to see before by bringing out the tissue characteristics at low energy or with the iodine images. I'm going to shift gears now and show you a patient who has a pancreatic endocrine neoplasm. And so we'll load that to start with into the pancreatic adenocarcinoma protocol because, again, unlike the adenocarcinoma where we're looking at the hypovascular mass in the background of the brighter enhancing pancreas, for pancreatic endocrine neoplasms we're looking for a tumor that is hyperenhancing relative to the normally enhancing pancreas. And so that same gain and contrast difference will be helping us to the reverse. So the tumor will appear brighter on the low energy images. And here it's ready to go. I'm going to start by making things a little bit bigger. And you can see right away, let's see, get rid of my little marker there, make it big on the coronals as well. In this patient, the pancreas and the tail pancreas are enhancing normally. There is no main pancreatic duct dilation. Rather, extending from the top of the gland, there's a hyperenhancing lesion. Now, it looks a little fuzzy here. This is a case from 2016, and it is our best acquisition using ACER of around 40%, but still there's noise because it's the source image. If you wanted to thicken these up, you could do that just by clicking here, okay, and get rid of some of the noise. For this individual kind of manipulation, you do have to change it in each of the windows, but I'll do that for you so you can see what you would be looking at more in a 3 millimeter thick slice, and the noise goes away. So here are hyperenhancing lesions that look like they're above or extrapancreatic, and that can happen with pancreatic endocrine neoplasms. If we look at the coronal, here you can see that the pancreatic parenchyma, here it is in the head. The neck, this looks like it's sitting on top, and that's a hint as to what this particular lesion is. Another important thing in this particular person is the fact that there's a lesion that is invading the posterior wall of the gastric antrum. So now we have extrapancreatic hyperenhancing lesions, a lesion that's invading the wall, and if I decrease the field of view, you can see that there are multiple hepatic metastases. So this patient has a pancreatic endocrine neoplasm that is predominantly extrapancreatic. It involves the posterior gastric wall, and there are multiple liver metastases. As I was referring to in the presentation, you want to know exactly how many and where the metastases are so that they can be resected. And as it turns out in this patient, just peeking behind the word water there on the iodine image, also visible on the 52 keV and 70 keV image, there's the 5th metastasis. Now, we actually look at hypervascular lesions in the liver with a slightly different protocol. Here it's called hepatic nodule, and it's real easy to step between these post-processing presets, and I'll show you that right now. So if we go to the one I like looking for hypervascular hepatocellular carcinomas, it's called liver nodule detection, and this basically shows lesions that are hyperenhancing as bright on a background of blue. We want to be doing this at a window level of 440, just like we would if it was a liver tumor, and here's what you get. You can see really quickly that tiny little metastasis up in the dome and all of the other metastases standing out as bright on the background of the brownish liver. Okay. I've got a cystic lesion that I'd like to share with y'all, and I'm loading that in now. I can, and I think I will, just deliberately load it into the pancreatic adenocarcinoma protocol so you can see the difference between evaluation of a cystic lesion versus a solid lesion in the pancreas. Okay, now we're looking at a patient who has a fairly large cystic lesion near the body of the pancreas. This patient actually had clinical acute pancreatitis several weeks earlier, and now we're looking at this collection, which we know to be a pseudocyst from disconnected duct. I'm just going to make it a bit bigger. And I'll actually pan this up. Select my pointer. And now, because there's such high contrast between the fluid in the cyst and the enhancing pancreas, you really don't capitalize on anything by looking at the low energy and iodine images. So we're going to switch out. We'll step right over here to our review steps. I'll look at my favorite protocol list, and we have something called pancreas cyst that we pop this into. Each time you change into one of the preset post-processing protocols, it takes just a moment, but not generally as long as it does when you initially load. This image looks kind of crazy right now because it's a mucin image, and that's probably an image you've never seen before in your life. It's hard to know how to window and level these, and I'm going to just get it where it looks. It's basically one type of virtual unenhanced image that you can do with this machine. So we get it where you can see the cyst. When I put a region of interest in here, I get something that's in milligrams per cc mucin. But I just want to show this, which is the 52 keV with the French filter that's just a color filter. I'm going to make this a bit thicker by just changing and clicking on the slice thickness so there's less noise. Basically, we can look in and around, whether we're looking at the virtual monoenergetic images, the mucin image, or this filtered image, and there's nothing in there that looks solid. So this is clearly just a pseudocyst. It doesn't have any septations, no nodules. It wouldn't be mistaken for a cystic mass because we know the patient had pancreatitis, and in here there's no solid component that should preclude drainage. So that's one way that you can look at a cyst in a patient with pancreatitis. And just as a comparator to that, my final case is one of a patient who has a cystic pancreatic neoplasm that has complexity, and you're going to see how that loads differently into the cyst protocol. So let's see if I can do that. Again, what we want to do with dual energy CT is to see things that we can't see with single energy CT, and being able to change the energy level of the images is important. To look for components like iodine or mucin is experimental on the mucin side, but still something we're trying to do. And I'm just going to make some adjustments here like I did before. So now it's a virtual unenhanced image that is based on mucin minus iodine. And if we take a look at this particular lesion, it looks a lot like the case I just showed you, except that when you compare the substance to the water in the stomach, it looks a little bit different. And here you can see that there are septations and nodules denoted by red. Now, I will say that we picked this one out when we were first looking at cystic pancreatic lesions. If you are red-green colorblind, this will not be the type of filter that you would want to be using, but there are many others. So here I'm just going to show you the choices of types of filters that you can apply to these various images in order to bring out pathology better and to your liking. So again, these are presets that are available to you. You can change anything in red to make the image bigger, change the window level, change the thickness, and even the preset steps can be altered when you find something that works well for you in your practice. So I hope you've enjoyed this trip using the GSI server, looking at how it does things differently. We can't use the color in PACS, but don't be afraid to use the dual energy images in PACS. If you're going to be looking for lower energy images or iodine images, you can program them to come straight off your CT console into your PACS and then use the server or the GSI workstation to your advantage when you need to delve more deeply into the dual energy information. Thanks.